Assalamu alaikum. Welcome to Journal Club of this week. The article this week is a case report from ENT literature. It's about acute epistaxis following sodium hypochlorite accident during endodontic therapy. It is a case report done by a group from Portugal. Most sodium hypochlorite accidents manifest as acute pain, rapid onset facial swelling, ecchymosis involving oral and facial tissues, and occasional nerve deficits. Sinonasal involvement is rare, particularly when presenting primarily as epistaxis. This report describes an unusual case of acute high-volume epistaxis secondary to sodium hypochlorite extrusion into the maxillary sinus following root canal therapy, managed conservatively with complete resolution. A woman in her 30s with no relevant past medical history presented to the ENT emergency department with sudden onset, high-volume anterior and posterior epistaxis within 30 minutes after undergoing primary root canal therapy of the left maxillary first molar. She reported a metallic chlorine-like taste in her throat but denied facial pain and swelling or visual changes. The patient had no history of hypertension, coagulopathy, or other predisposing factors for spontaneous epistaxis. There was no direct communication between the ENT and the dentist. It was only upon reporting of the patient herself, so this considers a limitation of the case report as well as the practice of the ENT and dentist without any communication between them. However, the management was conservative. After clot aspiration, nasal endoscopy showed diffuse mucosal erythema and mild edema, but no clear bleeding source. Mucosal necrosis or ulceration suggestive of chemical injury was identified. That's why it was diagnosed as sodium hypochlorite accident. The bilateral nasal packing with myrosol was performed, and intravenous infusion of 1 gram tranexamic acid diluted in 250 ml saline over 30 minutes achieved hemostasis, and the laboratory investigations including hemoglobin and coagulation profile were within normal limit, and the patient was discharged on a 3-day course of azithromycin 500 mg once daily. There was no CBCT from the dentist. However, the ENT department did a CBCT for the patient at the 3 months follow-up. The patient was asymptomatic and all the sinonasal structures were within normal limits without any even mucosal thickening. In conclusion, sinonasal sodium hypochlorite extrusion is a rare complication of root canal therapy. Although often self-limiting, it may present with acute epistaxis requiring urgent ENT evaluation. Awareness of such presentation, which is absence of swelling or significant pain, combined with immediate high-volume nasal bleeding and dysgeusia, suggests direct sodium hypochlorite entry into the maxillary sinus with the drainage into the nasal cavity. So among dental and ENT professionals, it is essential to be aware of this presentation for prompt diagnosis, appropriate management, and patient reassurance.